another live stream. What can I say? It's Wednesday night. We are all ready and willing to go. My name is Kane Treble, and I'm here tonight to run through some practice KFP questions, get ourselves ready for the 2024.1 KFP exam for RACGP. Good to have some of you in here tonight. Those that came in early probably saw I'd had to switch on subscriber only mode for the chat for a little bit. We had got some spam. Thankfully, that seems to have sorted it out. If we get some inappropriate comments in there tonight, I do apologise, and we'll keep chipping away. That's obviously turned off now for the live stream, so if you want to throw anything into the chat, tell me who you are, where you are, throw it in now. Of course, we are here for the content tonight, so without further ado, let's have a look at where we are at. We are, of course, 52 days until the 2024.1 KFP exam. Now, we are, of course, also coming up to Christmas, and I'll duck back here. A bit of fun, play around with some lighting. I'm in a bit of Christmas spirit. I love this time of year. Hopefully you are having a great time as well. So, we have 52 days to prepare, but I do hope everyone's actually having a bit of time off and doing a bit of self-care over the Christmas break. I appreciate we are kind of running down on time, and it's unfortunate to have to do some studying things through this period, but as long as you're having a bit of fun and spending time with family as well, I think that is definitely worthwhile at the moment. Okay, so we are going to spend a bit of time now on the idea of finishing strong. So we've gone through kind of the usual tricks that you can potentially fall for, ways to formulate responses. This is going to be focusing a little bit more on what to do once you've actually reached that next step and are wanting to actually go back through some of your answers. So one of the first things that I think, if you are going through and want to think about, am I right with these answers? Am I giving the best possible responses here? Think about potential variations to the question. Think about what would happen if I were to swap this patient's gender. What if I were to swap their age? If they're an older patient, make them younger. If they're a younger patient, make them older. If you swap around some of the signs or symptoms or risk factors, I want you to think, would that change your responses and why? Now, often the demographics they give are for very particular reasons. They're trying to assess very particular aspects of your knowledge of those conditions or that demographic. And so if you can think of something that would change if you change any of those factors, odds are you're on the right track there. Odds are you're giving something that's specific to that patient, specific to that case that they're actually trying to assess you for. So I'd strongly encourage you to try this out. And really what this is about is prioritising the key points from the case as it's provided. You want to also review this for clarity, ensuring that your answers are clear, concise, and that you're avoiding any kind of unnecessary elaboration, he says as he waffles on going through this slide. Moving on then, I want you to apply some critical thinking to it. And the easiest way to do that is just to ask yourself, is this actually what I would do in real life? They are pretty realistic in terms of when assessing these questions and responses. Is this something we would actually do in clinical practice? It's fair enough to just regurgitate guidelines, and often that will score you lots of points, but what they're wanting to know is, can you actually tailor the individual patient that's presented in front of you towards the answers that you've provided? Evaluate the priorities, what's actually important to that patient in particular. And if they mention particular complexities or particular aspects of that patient's social history is usually a good place to start looking for these things. Anytime they're giving you some kind of bit of social history, pay close attention, because there's a very good chance that is a particularly important aspect that they want you to acknowledge or respond to in some way, shape or form. Of course, then I want you to think about your time management. So once you've actually finished answering the questions of the exam, have a look at how much time you have remaining and divide that up into what are the key things you want to focus on. Now, of course, the number one thing you want to be prioritising here is going to be what are the flagged questions? What are the things that you've already noted? Hey, I don't think I know the answer here. I'm not as confident in these responses. Go back to those questions first and try and get yourself to the point where you're maybe not happy, but satisfied that you've got at least something down for those questions that you're happy to send through to the assessors. Next step, and realistically I think this is equally as important for the KFP exam in particular, scan for the errors. And the common things, as we've spoken about multiple times here, ask yourself, have I actually answered the question written? It's easy to read through the STEM and perhaps get a little bit lost as to what exactly they're looking for. Really read that question carefully, check your answers, make sure that your answers are actually answering that question that they've asked. Again, keeping things nice and specific and concise. An easy way to score extra marks here is if they specify a left arm, include left in your answer. If they include acute versus chronic in your answer. These are all little things that, again, in clinical practice, we kind of just take for granted, but we're wanting to have that specific information in our responses. The usual culprit of avoiding abbreviations. We've spoken about this time and time again, and unfortunately it's a place that I think a lot of people lose marks. The official stance from the RACGP is they will not accept any abbreviations. CT, MRI, AF, doesn't matter. You really need to be spelling things out. If you're not 100% sure of the spelling, that's fine. That's okay. I don't know how to spell a lot of things either. As long as they can kind of get the gist, get the feeling of what you're trying to convey, you're fine. Overcoding we've spoken about as well. This is the no ifs, ands, or buts. If you're giving two answers in one statement, that's overcoding, and particularly damaging because you not only miss out on marks if you put down, say, two things in one line and both were worth multiple marks, you're going to lose the marks from that second response, but you're also going to have marks actively deducted from your answer for that question by overcoding. And that's a percentage removed for every instance of overcoding from your complete exam score. Finally, have a think. Have I actually diversified my answers enough? Am I giving all answers in the same family or towards the same goal? Do I need to be spreading out some of those responses somewhat? And then the final read through, if you have any time left, just have a quick read through and make sure the comprehension's there. Make sure you're actually conveying the message you want to be getting across there. And I think as long as you're doing these things, you're going to do pretty well. Now, of course, we are also here for questions tonight. We've got 3 cases prepared, each with 3 different questions in there. So without further ado, let's get 2 minutes on the clock, and your time starts now. All right, time is up, and let's get through some of the answers here. Now, there's going to be lots of things that could be happening as to why Zara might be experiencing worsening symptoms or changes in mood despite the ADHD diagnosis and medication, which has previously held things in control. Fantastic guidelines available for this, which I would strongly recommend every GP become familiar with. These are relatively new, and so I think it is one of these things that we are seeing so many new cases, so many new presentations, and just as important, so much public interest in ADHD and potential diagnoses or misdiagnoses. This is something that I think we're really obliged to know a fair bit about. Now, in this instance, we have the diagnosis, we have medication, but we're still seeing troubles. What could these causes be? Lots of things. We could be seeing tolerance to the medication. So it may actually be that the medication dose as prescribed is insufficient. There could be abuse of medication as well. These are stimulant medications that unfortunately do have abuse potential, and it may be that she's not using it as prescribed. Kind of the opposite of that in some ways is forgetting or poor compliance with the medication. So it may have held things in check previously because it was being taken consistently, and now, unfortunately, maybe not. And there could also be coexisting other psychiatric conditions such as anxiety disorder or depression. And I think as long as you're giving any kind of sensible response, you're going to be getting the mark there. Now, we are using stimulants, but there may be other substances being used or abused. You could also give specific examples here, and I think anything in that kind of family would be grouped and giving you a mark there. Teenagers, sleep, always going to be an issue, and I think it's always something worth exploring, particularly with any kind of changes to mood as well. Exploring that as well, you're also going to get information, collateral history for things such as underlying anxiety and depression. And we could also be seeing an underlying medical condition such as thyroid dysfunction. Again, I think as long as you're putting some kind of sensible option in there, you'd be getting marks. Hearing or vision impairment, which I know it sounds silly when we're talking about a 17-year-old, but you can have people who are diagnosed with these things very late in life. They've found ways to cope or adjust in some way, shape or form for a very long time before it's been detected. I myself only got glasses when I was 19 years old, I think, when I was just getting headaches all the time whenever I was staring at computer screens, which at that time were becoming more and more prevalent. And I just thought, this is how everyone is. And I'll never forget, and you'll hear this from everyone that wears glasses, the first time you put them on and you say, oh, those are leaves. I can see leaves. It was a very exciting moment, for me at least. Okay, moving on. I have specified anemia here. I know we've already kind of said any underlying medical condition. I think anemia is probably worth having as its own special little thing, partly because so many things can cause anemia, but this is something that I think in a 17-year-old, multiple potential causes, and would definitely be worth exploring as its own individual point. Again, if you're not familiar with these guidelines, grab them, read through them, at least the summary table. The summary table is pretty nice and relatively concise, but is an excellent point to just kind of brush you up and kind of get your knowledge up to date. Of course, we have more questions, so let's put 2 minutes on the clock and your time starts now. All right, time is up. And I think this is something that we're all relatively familiar with, all of the pharmacological management options for ADHD diagnosis. Of course, there's so much more to ADHD than just stimulant medication or medication in general. And so I think it's really important that you do have a good hold of what are the things that we should be doing alongside that. And in fact, there are many, many cases of ADHD that are managed just using non-pharmacological interventions. And I think as well, there is a bit of stigma now for those who are exploring diagnosis that, oh, you're just after medication. And sometimes that might be true. But again, I've had probably just as much success with people just undertaking these non-pharmacological management options in terms of getting their life back in control again. Of course, easy marks if you throw in CBT, everyone's favourite. And of course, avoiding abbreviations. There it is. Avoiding abbreviations, cognitive behavioural therapy. A big part of ADHD management is also about structured routines. And it may seem a little bit odd, telling a 17-year-old to enforce a structured routine, but it does make a massive, massive difference. Tied into that as well, we know that regular moderate exercise, 30 minutes per day, at least 5 days per week, also has profound impact on ADHD management and symptom control. Other strategies such as mindfulness or meditation, again, giving some centering and ability to de-escalate. A big part of managing ADHD is also about the parental and family training. A lot of groups that manage particularly younger kids with ADHD diagnosis is actually centred around educating the parents more than anyone else. Now, we are still in high school. It has specified that in the STEM, and so really important to note that high schools also have incredible support services and counselling services available and would definitely be worth tapping into in this instance. And of course, there's also your usual support groups and online services that could also be tapped into as well. So lots of potential answers there. Hopefully you've got a few down yourself. This is, again, one of those situations where you're going to have multiple options available to you with only fewer that you can put in. So try and prioritise the ones that you think are going to be most important, most applicable to the patient case. In this case, pretty much all a fair game, given there's not a whole lot to go on in terms of which direction you should be taking. All right, now we have another question, so let's get 2 minutes on the clock and your time starts now. All right, time is up. And again, this is one of those questions, and you will see ones just like this in the actual exam, where they're really steering you towards answering in a particular way. So obviously lots of things can cause loss of weight in a 17-year-old female, but they're focusing in, they want you to really focus on the medication being the potential cause here, and what are the things you can do around that. Again, going through some of these guidelines here, and this is something that you will see not uncommonly for particularly younger people, I think, with these kinds of medications. Taking the medications either with or after food rather than before meals is shown to boost weight or at least minimise weight loss. Taking additional meals or snacks earlier in the morning or later in the afternoon when the stimulant effects have actually worn off will also increase weight gain. You can also refer to a dietitian for meal planning or dietary advice. You can just encourage higher calorie foods of good nutritional value. Or taking a planned break from treatment. Now, that one there wouldn't get you marks because in particular, she's actually advised that she wishes to remain on the current regime. Similarly, trying to change or stop medication, which would be a potential option just in general, isn't going to get you any marks in this case because she said that she's keen to remain on the current regime. This is one of those cases where you have to read the question being asked and make sure, yes, they're valid treatment options, but not applicable to this particular case. So always read the question being asked. All right, so that is case number 1 finished up. If you're up to this point now, I want you to make sure that you're actually dragging the little red bit down the bottom, making sure you're up to date so that any answers you put through are going to be live for here. There can be a bit of buffering sometimes, which brings your position backwards. And so to try and make sure everything's live, just make sure you're live as well. Okay, so case number 2, let's get 2 minutes on the clock, and your time starts now. Right, time is up, and you may have noticed I've made a typo. It's question 2.1, of course, but that's all right. Going ahead to the answers. Now, oh, there we go. I fixed it here at least. There you go. Again, this is one of those questions, and you might notice a bit of a theme tonight. I'm really trying to push that thought that they're going to know you-know diagnosis. They're going to know you-know management. We want to focus, though, on the patient that's in front of us. And that's one aspect, love it or hate it, that I think the KFP actually does reasonably well, is that it gets you to actually focus on the actual presentation itself, the person presenting with the symptoms. as opposed to just your knowledge around these conditions. And so I want you to think about what are the age-related or comorbid factors that could contribute to worsening psoriasis in an elderly patient. And so we have lots of options here. Again, more options than there are marks. Reduced skin barrier function. The older we get, the more frail our skin becomes, and that's going to make it more prone to outbreaks and flares of psoriasis. Of course, with age as well, we've got cumulative UV exposure causing increasing damage, irritation, and again, increasing that risk of flares. Well established that the older we are, the less functional our immune system becomes, and tied into that, we know that there is autoimmune components to conditions such as psoriasis, and so with that altered immune function, we can again see increased flares. Comorbidities such as hypertension, so cardiovascular in particular, are very well known to be associated with psoriatic conditions, and of course amlodipine. So antihypertensives in general, but amlodipine in particular is well known to potentially exacerbate psoriasis, and so you'd be considering switching that out for another agent. Hopefully that makes sense there. Probably one other thing I would like to mention is diabetes. Not specifically mentioned here, but diabetes is a very well-established comorbid condition that correlates with poorer control of psoriasis. Now, it doesn't apply to this particular case because there's no mention of a history of diabetes, but I want you to have a look at your diabetic patients, and I wouldn't be surprised if you do notice an increased rate of psoriasis. And definitely, as they get older, important to manage. All right, now let's go to the next question. We'll have 2 minutes on the clock, and your time starts now. All right, so time is up. And for this, we've only really got one option here, and that, of course, here is methylprednisolone acetonate. And you would have to actually specify that for the full marks. There's multiple different formulations, and so if you want to be specific, that's going to be your answer. You would still get 1 mark by putting methylprednisolone, and so that if you're kind of really struggling to remember which version, which formulation you want, you're still going to get a mark for putting that down there. Now, the thing that makes this this is the answer is the fact they've specified this is flexural psoriasis, and so you do have to manage this in a very particular way. This is, of course, using ETG as the guidelines for it, and I've posted that onto there. But we do have to think about what other measures we would be using, and I would strongly recommend, if again this is something that you're not as familiar with, read up ETG, but also DermNet have some absolutely amazing resources, so I would have a look. All right, now, of course, we have a third question on here, so we'll put 2 minutes on the clock, and your time starts now. All right, time is up, and everyone has their thing. Eyeballs, I don't know. Everyone's got a thing. I don't mind like working with feet, fine. Eyeballs for some reason, just. Anyway, moving on. So this here is a case of blepharitis, anterior blepharitis in particular, and this is really given away by the erythema around the eyelid, the changes to the eyelashes, and some crusting present as well. Very commonly associated with psoriasis as well, and so would be something you'd be keeping an eye on, particularly as the patient ages, more likely to encounter things like this. And so what initial management options do we have? List 2, we've got lots. Warm compresses applied to the eyelids daily for 2 to 5 minutes, 4 marks. You have been specific and concise. If you just mention warm compresses without any further kind of clarification, you're still going to get a mark, but come on guys, stretch it out a little bit, get those extra details in there and you will get extra marks for it. Likewise, gentle scrubbing of lashes with sodium bicarbonate solution, 2 marks, fantastic. Gentle scrubbing of lashes with baby shampoo, full marks, fantastic. And it'd be one or the other of those. It's not something you would do both of, and so in all likelihood they're going to be grouped together. Now if you just specify gentle scrubbing of lashes, 1 mark, come on guys, we can do better. And the chloramphenicol eye drops, or eye ointment in this case, wouldn't actually be worth any marks. That's second line if conservative management's not treating and there's concerning evidence of infection, which in a case like this, there just isn't. It's a relatively clear-cut blepharitis, so I don't think you would get any marks there. All right. Moving on, we are, of course, up to now case number 3. Again, if you want to make sure your responses are up to date and synchronised with the live of the live stream, make sure your little red thing down the bottom is as far to the side as possible. Buffering. We're getting a few buffering errors tonight, so apologies if you're getting the little circle of doom. All right, case number 3. Let's get 2 minutes on the clock, and your time starts now. All right, time is up, and hopefully you have some answers put through. So this here is a case of high output stoma, and of course lots of things can happen. Now, probably important to note is I've intentionally made this a 3-month after. You usually get a bit of high output in the period immediately post-op. Usually by about 3 months, things are starting to settle down. So I wanted to push things away a little bit from there, but of course we have to acknowledge this is still a pretty recent operation. Now, this could actually be further complications of ulcerative colitis. We've got an established diagnosis, and so this could just be plain old malabsorption due to ulcerative colitis. And that is one of those kind of sounds like a duck, quacks like a Sounds like a duck quacks like. Of course it does. If it quacks like a duck and walks like a duck, it's probably a duck. Now, of course, then you have to ask, well, what are the things we wouldn't want to miss? And in a case like this, it would be malignancy, small bowel, something like lymphoma. If you're giving some kind of sensible kind of option to acknowledge the malignancy risk, I think you'd be getting 2 marks there. Now, of course, this could just be simple infection. I think less likely given the chronicity of it, but you can't rule it out completely, and so it would be something you would keep in the back of your mind. And, of course, excessive fluid intake. So it's one of those, a lot goes in, a lot comes out kind of situations. For overactive stomas, we are looking at volumes over 2 litres per day. So roughly, if we take a step back for a second, you get 9 to 10 litres of fluid moving through the bowels per day, and 85-90% of that's going to be absorbed, which leaves 1.5 litres, 2 litres to be reabsorbed by the colon. This means you can normally expect 1 to 1.5 kind of litres per day. As you're getting above 2 litres, though, you're really heading into that kind of higher output, more difficult to manage, more likely to see complications kind of territory. And so there's no actual fixed definition of high output, which is why I haven't specified a particular amount here. I just wanted to say, look, it is high output. But yeah, this is something you have to keep in the back of your mind. Now, stress or anxiety, well known, well established to have impact on bowel activity, and so would be something you would have to acknowledge as well, particularly when this all seems to be relatively new, relatively big changes for him. So you'd want to explore that carefully. Now, there could also be surgical complications, be it something like an anastomotic leak or some kind of suitable example. You'd be getting marks there. If you have a look at the side effects of mesalazine, you can actually get high stoma output as a complication of that. You would also get marks by medication side effects as well. Bacterial overgrowth is well known to increase the amount of output, and that's through changes to normal gut flora, which will cause increased output. And of course, always remember your endocrine disorders as well. So adrenal insufficiency, thyroid dysfunction, all things that have been proven to have a strong correlation with stoma output. All right, now let's get to question number 2 then. We'll put 2 minutes on the clock and your time starts now. All right, time is up. Now, this is one of those things as well that I think you have to in some regards, force yourself to become exposed to managing stomas or dealing with patients with stomas. And if it's not something that you've done much of, I think it's important to try and find a way to expose yourself or do some reading up, because it's incredibly common. And I think it's one of those things that if you don't know much about it, it's easy to kind of say the wrong thing or make decisions that may not be in the best interest of the patient. So just as important as actually managing the stoma output is all of the other things that go along with a high output stoma. And anyone with a stoma will tell you skin is just the number one priority. You've got to really try and protect that surrounding skin, because if that starts to break down, you're in a whole world of trouble. So discussing peristomal skin protection or looking at appliance modifications to make sure the bags are sticking properly, you're not getting excessive excoriation or infection or breakdown, would be definitely worth 2 marks. Now, of course, we are losing high volumes of fluid. We're bypassing large sections of bowel. You'd be wanting to keep an eye on electrolytes, so you'd be doing regular pathology. Tied into that as well, we've lost a large chunk of bowel here, so we need to also discuss nutritional support, and I think it would be very, very reasonable to be referring to a dietitian for further advice or management options there. Of course, this is someone who's gone through a lot, and so talking through the psychological support, whether it's referral to a psychologist or just starting the patient on cognitive behavioural therapy would also definitely get you marks. There are dedicated stoma nurses for further stoma care, and again, that's referring to someone and specifying what for in particular. It's one of those things where some country towns have it a little bit more rough, have it harder, but again, this is such a common occurrence that I know the larger rural centre where I am, we have stoma care nurses. So find out what's available in your area. Now, there are also massive support groups for this, again being a very common thing, just not often discussed. And one of the bigger ones you'll hear about time and time again is the Australian Council of Stoma Associations, which is kind of a body overseeing many other organisations. So it's a fantastic place to get into contact to see what may be available in your local area. They can usually point you in that right direction. Again, if you don't have much experience with it, you probably don't know, but there is a stoma appliance scheme which gives financial support and access to consumables for those with stomas. The costs of all the consumables is absolutely staggering, and so proper stoma care can be limited by a patient's ability to actually afford all these things. Now, this is something that if you haven't done, a stoma nurse or support group would definitely be linking them in with, but it should be something you'll be involved with. Often needs a doctor's signature to authorise release. In the setting of high output stomas, to say, yes, there is a high output stoma that's going to require extra consumables. Tied into all this, booking for regular reviews, really, really important to make sure that you're then following up and making sure this isn't becoming a bigger issue. This is one of those things, the sooner you can jump on any problems, the much better the outcomes are for the patient and for yourself. Save yourself some grief and just book in those regular catch-ups. Ideally, you would also specify timeframes to really be specific and concise, and so I would want you to specify, weekly, fortnightly, monthly, whatever you think is going to be appropriate, and I think realistically, given the slight ambiguity of the stem here, as long as you specify some kind of time frame, you're going to get the marks. All right, coming up to the next question, the final question for case 3 tonight. Let's put 2 minutes on the clock, and your time starts now. All right, so time is up, and look, we've got lots of options here is the good news. And one of the important things is to look at, well, what are we putting in the first place? So important to mention that you're specifying adequate dietary fibre intake with high soluble and low insoluble fibre. If you just were to say increased dietary soluble fibre, yeah, you'll get a mark. If you just say increased dietary fibre, you're not going to get marks. Because it's really, really important, and I've unfortunately seen cases where people have been told it the other way around and made things quite difficult for the patient involved. So you want to avoid foods rich in insoluble fibres. That's bran-rich breads, cereals, some fruits and veggies, legumes, dried beans, and you want the foods that are high in soluble fibre, so stuff like oats, rye, barley, apples, bananas. There's plenty of lists out there if you want to know kind of what's safe, what's not safe, and the association I was mentioning before actually have a really nice kind of write-up on different options and different foods available, so have a read of there if you're ever kind of stuck or not sure. Now, of course, high output stoma, we have different anti-diarrheal medications. Probably the easiest one to get a hold of these days is going to be loperamide. You can use codeine as well, and you can get straight codeine tablets. Used to be wonderful to be able to get codeine linctus, unfortunately no longer available, but there you go. So I think as long as you're specifying some kind of sensible option there, you're going to get a mark. There is a lot of evidence as well to say consider a probiotic to try and balance the gastrointestinal flora. As you're having that high output, you're going to strip a lot of your protective bacteria with that. You can reduce oral hypertonic fluid intakes, that's tea, coffee, water, juice, anything that is going to kind of shoot through. And again, kind of then tied into that is what are the other things we can put in there? And that's going to be sipping oral glucose or saline kind of solutions as a fantastic little option. Now, you can also use ranitidine or omeprazole. So ranitidine 300 milligrams oral twice daily and omeprazole 40 milligrams oral daily. You can use it intravenously as well, twice daily for severe cases. Has a pretty significant impact on stomal output. So again, the IV access is not something I'm going to be expecting you to do in general practice setting, but a trick to have up your sleeve if you're ever needing to know. But certainly oral ranitidine or oral omeprazole, fantastic options if your patient isn't on those things already for coexisting reflux or something else. So yeah, keep that up your sleeve. All right, that is our 3 cases done tonight, and I also wanted to finish up by just giving a little update about the course I've been preparing, which contains a lot of the little sessions kind of I've been doing at the start of these live streams, going through dedicated ways to actually answer the questions. It's something that's not actually going to be ready by 2024.1, unfortunately, but I'm hoping to get it up and ready for 2024.2, and I'll be using the kind of gap between 1 and 2 to finalise and put it out there. So apologies, I was hoping to get it ready for you guys. Just hasn't been able to happen. Life's kind of gotten in the way. What I would love, though, is if you're able, willing, throw your name down in the comments, and I'm really, really keen to try and get people through what content I do have already, if it's something you would be interested in getting access to, even though it's incomplete, for feedback and suggestions, and of course, when it is actually finished, I'll be giving you ongoing access to provide further feedback from, now that you've actually sat the exam. Of course, if you did find this helpful, give me a like, give me a subscribe, the cheesy kind of YouTube things. But knowing that I've got those things there is that little bit of incentive for me to keep going. So also want to specify that thank you from the depths of my heart for joining these live streams. Showing that commitment and dedication to passing the exam is absolutely remarkable, and you should be proud of yourself for doing this stuff as well. I really appreciate as well that you're sitting up here on a Wednesday night away from your family, striving to be the best GP you can be. I think as the exam approaches, you should take pride in these accomplishments, as little as they may be, time by time, and know that this ends, this finishes, and life does go on. No matter how you feel when you're in the exam, remember that your commitment to all this is absolutely unquestionable, and your hard work will pay off, not a doubt in my mind. So, without further ado then, I'll leave you guys to the night. If you have anything else you want to ask, throw it in the chat. I'll hang around for a little bit. And of course, if there is any other questions, feel free to comment on any of the videos as they kind of upload as we go along. Until then, of course, thank you for joining me. And this will be the end of tonight's live stream. I wish you well for the rest of the week. And yeah, Merry Christmas. See you next week.